Thank you so much. So it's my pleasure to be here with you today to discuss a recent work by the PDOPPS group looking at variation in PD-related peritonitis outcomes and treatment practices. So this OPUS sub-study was supported by a grant from the USAHRQ, and a full list of DOPPS funding can be provided here. So peritonitis is actually a very concerning complication in peritoneal dialysis patients. And despite the advances in peritonitis preventive strategies, it has actually remained the leading cause of technique failure and transition to hemodialysis in many countries. So we need to identify different characteristics and treatment practices that can maximize the likelihood of cure, and also that is associated with a reduction in peritonitis-related adverse events. So as we can see in this chart bar, peritonitis is the most frequent cause of technique failure and transition to hemodialysis among all countries enrolled in the PDOPPS. So our objectives were to describe regional differences in peritonitis cure rates in countries enrolled in the PDOPPS, and also to explore the impact of different characteristics and treatment practices on the likelihood of cure following peritonitis episodes and on individual adverse events, including death, PD catheter removal, transfer to hemodialysis, and relapse or repeat peritonitis. Now, the absence of these events within 50 days of peritonitis onset constitute a cure. So we use PDOPPS data from Australia, New Zealand, Canada, Japan, Thailand, United Kingdom, and the States. We included patients 18 years of age or older who were receiving maintenance PD from a random national samples of PD facilities that treat at least 20 PD patients at the time of selection. We excluded patients using hybrid, and those were mainly in Japan. Our primary outcome was a cure, while secondary outcomes were hemodialysis transfer, death, catheter removal, and recurrent or relapse peritonitis. So coming to the result, we identified 1,677 peritonitis episodes in 1,190 patients, and the total number of facilities were 126. The overall peritonitis cure was 63%, with some variation by country. So in Japan, around 68% of episodes resulted in a cure, while Thailand had the lowest cure of 54%. In terms of adverse events by country, we did notice significant variation in mortality. For example, as we can see in the blue bar, Thailand was associated with the highest mortality, with 15% of episodes resulting in death. On the other hand, Japan had the lowest mortality at 2%, and in the remaining countries, it ranged between 4 and 6%. So for peritonitis cure by organism, compared to gram-positive peritonitis, unsurprisingly, fungal peritonitis were associated with the lowest odds of a cure. Also, polymicrobial culture-negative and gram-negative peritonitis were associated with lower odds of a cure compared to gram-positive. We also identified some characteristics and practices that are associated with peritonitis cure. For example, patients with the previous peritonitis episodes had lower odds of a cure compared to no previous peritonitis. Also, APD modality was associated with higher odds of a cure compared to CAPD. The higher serum albumin, the higher odds of a cure. And unsurprisingly, concomitant exit site infections were associated with lower odds of a cure, perhaps because some of those episodes would require catheter removal. Also, in facilities practices, the higher percent of icodextrin use was associated with higher odds of a cure. So here we wanted to see if empiric antibiotic treatment made difference in terms of the outcomes. So we looked at gram-positive empiric antibiotic treatment, and we looked at gram-negative empiric antibiotic treatment. While there was no difference in outcomes with the use of Cefazoline or Vancomycin as empiric gram-positive coverage, we did find that for gram-negative peritonitis, there was much higher odds of a cure with using aminoglycoside compared to ceftazidime for empiric gram-negative coverage. Now, the ISPD suggests using either of those antibiotics for empiric gram-negative coverage. However, I think this finding is important, especially with the emergence of cephalosporin resistance organisms, such as the ESBL, which has been a problem in many countries. So in terms of secondary outcomes, I just want to highlight here the significant higher odds of relapse or recurrence in patients with more residual kidney function. And this is possibly related to the clearance of the antibiotics in the urine in patients with more residual function, which can result in subtherapeutic antibiotic levels. So coming to the limitations, although this was the largest international studies looking at variation in peritonitis outcomes and treatment practices across 7 geographically diverse countries, we do have several limitations, including, of course, the observational nature of the data, the possibility of center selection bias, as some centers actually might be different than other centers within the same country in regard to PD practices. Also, the lack of organism antibiotic sensitivity data and antibiotic dosing. And lastly, given that our sample consists largely from high-income countries, our sample might not be generalizable to other countries with low incomes and resources, although we did include Thailand in the analysis. So what are the take-home points? In all countries, we have observed unacceptable low cure rates, and that suggests that we need novel interventions to prevent and treat peritonitis. Also, the fact that most of peritonitis outcomes are driven by the causative organism. So we need a better organism identification methods, particularly to reduce the risk of culture-negative peritonitis. Also, we need a better organism-specific treatment strategies. And in this regard, aminoglycoside use actually might be superior to other antibiotic for the empirical treatment outcomes following gram-negative peritonitis. That would be all for me. Thank you.